Now, a lot of our management after a patient has suffered from a myocardial infarction is aimed at anticipating, preventing and treating complications that may occur. And we want to run through some of these complications on this diagram. So here we have a basic simplified diagram of the heart, the left atrium and the right atrium, the left ventricle, right ventricular. These are the papillary muscles here, connected to the chordae tendineae, the tendinous cords, which are holding the valves in place and preventing overexpansion of the valves, resulting in reflux. This is the cardiac septum. This is the aortic valve with the aorta, the pulmonary valve with the pulmonary artery. In life, of course, there are 4 pulmonary veins carrying blood into the left side of the heart, and we have the superior and inferior vena cava. So that's the basic diagram we want to use. Now, perhaps the main cause of death after a myocardial infarction is ventricular fibrillation. And many of these deaths occur before the patient reaches our care. So the patient can have a myocardial infarction and go into ventricular fibrillation. And if there's no defibrillation facility available, then that ventricular fibrillation will not spontaneously revert and the patient can die. So what typically happens if there's an area of infarction here, say, this is the infarcted area of myocardium. The muscle cells in this area, the myocytes, are deprived of their oxygen supply and they start to die. And as they die, the membranes become electrically unstable and they can start generating ectopic impulses that spread into the adjacent myocardium. And as these cells are dying, they become very electrically unstable and the polarization and depolarization can switch off a couple of hundred times a minute. And the myocardium tries to respond to that, but it can't. So you end up with a rapid, uncoordinated, chaotic, quivering type of contraction. It's kind of like this. The myocardium is just quivering and there's no effective contraction at all. That means there's no cardiac output. That means the blood pressure essentially drops to 0. This is a cardiac arrest situation. And if a patient's in ventricular fibrillation, the only possible treatment to correct that is electrical defibrillation. Of course, if we're waiting for defibrillation to arrive, we give chest compressions, where we compress the heart between the vertebral column and the sternum and the ribs. As we do that, that's going to increase the pressure in the chambers of the heart. Blood's going to be ejected out into the aorta and pulmonary artery. Blood will be sucked back in from the great veins and we will generate a cardiac output. And because there's a cardiac output, the myocardium itself can be perfused, the brain will be perfused, and we can buy time while we're waiting for advanced life support, while we're waiting for defibrillation to arrive. And of course we'll need to oxygenate the patient so that the blood returning to the heart via the pulmonary veins is fully oxygenated. And even in patients that arrive in our care, maybe 5, even 10% of hospital patients can still suffer ventricular fibrillation after a myocardial infarction. Now, the likelihood that ventricular fibrillation develops is not dependent on the size of the infarct. It's independent of the size of the infarct. It's related to the electrical instability generated by the infarct in the myocytes. So someone can actually have a very small myocardial infarction but still die from it. And this is part of the reason why, if we can get someone back, if we can revert them after an early ventricular fibrillation, then that patient's prognosis is the same as if they never went into ventricular fibrillation in the first place. And this is, of course, is why we monitor these patients carefully, to look for the possibility of this so we can treat it as soon as the patient becomes unconscious. Now you can get a similar situation in the atria. You can get atrial fibrillation where there's no effective contraction of the atria. Very often the cardiac output can be maintained in this situation, although we might want to treat this by giving digoxin or beta blockers. If the atrial fibrillation goes on for a long period of time, we can get stagnant areas of blood in the heart, which can give rise to thromboembolic complications, so we might want to anticoagulate these patients. Other patients go into a fast atrial fibrillation that's associated with hemodynamic disturbance, tachycardia and hypotension. And with these patients we might want to consider the emergency treatment of synchronized DC shock, synchronized defibrillation, after of course we've anaesthetized the patient. Now, as you probably know, the pacemaker is up here, the sinoatrial node is up here, the atrioventricular node is here. The impulses generated in the pacemaker go across, causing contraction of the atria, picked up by the atrioventricular node. This passes the impulse down the atrioventricular bundle of His into the right and left bundle branches and on into the Purkinje fibres, which cause the depolarization of the myocardial cells. Now, if this normal conducting mechanism is disrupted, for example by an infarct, then that can mean there's a degree of heart block. So if there was a disruption at this level, the impulse might come across here normally, but not be effectively transmitted down into the ventricles. There's a heart block. And this often gives rise to a bradycardia. The heart rate becomes slowed. And if the heart rate is slow enough to reduce cardiac output, to reduce blood pressure, we can consider giving these patients some atropine. But very often, as long as we give effective reperfusional therapies, PCI or thrombolysis, this situation will resolve fairly quickly. If it doesn't, in some cases we need to pass a pacing wire. An emergency pacing wire is often passed into the left subclavian vein. If it's passed into the left subclavian vein, can you see it's going to enter via the superior vena cava, go down through the right side, lodge near the cardiac apex, and a regular impulse can be electrically administered to the cardiac apex, causing cardiac contraction. At any pace we set the machine to, we can set the pace of the machine. So heart block is a possibility, particularly if there's right coronary arterial infarctions. So it can be associated with inferior myocardial infarctions. So we're looking at the patient's heart rate to make sure it's not slowing down, and we're looking at the blood pressure to make sure the heart rate is adequate to maintain a blood pressure. If not, we can consider treatment for heart block. So it's a bit ironic really. I suppose you could say that ventricular fibrillation is far too fast and heart block is far too slow, both resulting in greatly reduced pumping efficiency of the heart, both resulting in reduced cardiac output with all the consequences that are associated with that. So many other possible types of dysrhythmia can present. We need the patient on a 3 or a 5 lead ECG. We need to monitor them, and the more serious dysrhythmias like ventricular fibrillation are going to occur early, very often before the patient comes into our care, but in the first few hours typically that the patient is in our care, that they need very close supervision of the cardiac rhythm. Now, another group of complications that patients suffer from are ongoing ischemia. The original pathology that occluded the coronary artery that caused the thrombosis is still there, and the atheroma results in continuing ischemia. And here we need to consider reperfusional therapies such as stenting in the coronary arteries, or possibly coronary artery bypass grafting to relieve the ischemia. And both of those procedures are associated with a very good prognosis, as we can reperfuse the blood supply to the myocardium. Now, another group of symptoms are associated with heart failure. Now, one possibility is left ventricular failure. If the left ventricle fails, if there's an acute left ventricular failure, possibly because of a dyskinetic area of myocardium, then I think you can see that can reduce cardiac output. If the left ventricular failure reduces cardiac output to the point at which the tissues of the body become hypoperfused and hypoxic, that would be classified as a cardiac failure. But I think you can also see that in cardiac failure, if this ventricle is not pumping properly, then the blood will be left in here at the end of systole. More blood will be left in here. That's going to make it harder for the blood from the atria to get through to the ventricles. There's going to be a backlog of blood. That's going to cause a backlog of blood in the pulmonary veins. That's going to increase the capillary pressure in the lungs. That's going to reduce the reabsorption of tissue fluid from the lungs, resulting in pulmonary edema. So in left ventricular failure, we have one pathology, but two main manifestations. One is the heart failure with the reduced cardiac output, and the other is the backlog of blood leading to pulmonary edema. So that's one manifestation of heart failure. Now, heart failure can be more severe than that. If the left ventricle is very dyskinetic and not pumping well at all, that can result in a significantly lowered blood pressure, and if that is low enough, we would classify that as a cardiogenic shock. So very severe heart failure caused by a large dyskinetic area of the left ventricle can lead to cardiogenic shock, one of the causes of cardiogenic shock. But heart failure can also develop in the months and years after an infarct has occurred. And one of the common reasons for this is ventricular aneurysm. And this can affect up to 10% of patients after acute myocardial infarction. Now, the term aneurysm normally refers to a weakness in the wall of a blood vessel, but in this case it's in the wall of the heart. And typically a ventricular aneurysm will occur after a transmural myocardial infarction. So a transmural myocardial infarction means that the whole thickness of the myocardium is involved. The whole thickness is involved in a transmural myocardial infarction. And this leads to scar tissue formation, mostly collagen. And the scar tissue is acontractile and it stretches and thins. This is called infarct expansion. And this leads to progressive dilation of the ventricles, and there's often a compensatory hypertrophy in the non-infarcted areas. Let's see what we mean by this by looking at this diagram here. So here we see that there's been an area of transmural infarction. You can probably see this is the left ventricle, left atrium, aorta, pulmonary artery, right side of the heart here. And here the myocardium has been replaced by fibrous scar tissue, which doesn't contract, but because of the pressures in the heart, it's going to expand and dilates, causing a ventricular aneurysm. Now, as the ventricle dilates, the overall contraction becomes less efficient, and this is what can lead to heart failure. And there's also a possibility of mural thrombus forming over the infarcted myocardium. So what you can have as well is areas of thrombus formation that can develop round about there. And I think you can see they could wash off into the systemic circulation, so-called mural thrombus. And as there's anatomical disorder of the ventricles, ventricular fibrillation is a possibility and may be a cause of later cardiac death. So because this is abnormal electrical activity in the myocardium can be aroused, leading to possible ventricular fibrillation. And in the out of hospital situation, that's likely to cause sudden death syndrome. And if you take a 12-lead ECG, you'll see persistent chronic ST elevation. And of course, echocardiography is completely diagnostic. Now, of course, you can always take a surgical opinion on this, but these patients are normally put on ACE inhibitors, angiotensin converting enzyme inhibitors, to prevent or delay the onset of cardiac failure, because there's increased pressures in the surviving myocardium. This leads to remodeling over months because you get increased workload in the surviving myocardium, and that's going to lead to hypertrophy. And as we know, hypertrophy leads to failure. So ACE inhibitors can be very effective at preventing the onset of cardiac failure, even in the presence of significant ventricular aneurysm. Now, I think we'll go back to the first diagram just to mention a final few complications. There's always the possibility of mechanical failure, gross mechanical failure after infarction. For example, if there's infarct of a papillary muscle, one of these muscles here are connected to the tendinous cords. If there's an infarct in that muscle, an area of infarcted papillary muscle, there'll be dead tissue here, and the whole muscle can essentially detach. There can be a rupture of a papillary muscle. And this means that this tendinous cord will not be working. This means that this valve flap can overexpand, causing the blood to regurgitate backwards, greatly reducing cardiac output. So rupture of a left ventricular papillary muscle can cause acute severe mitral regurgitation. That can result in acute severe pulmonary edema and shock. Again, we can confirm this diagnosis with emergency echocardiography, and we can refer to the cardiothoracic surgical people for possible mitral valve replacement. Lesser mitral regurgitation is more common and can be transitory, but this is an acute life-threatening condition. Another one is a ventricular rupture, where the blood can actually get through a dead area of myocardium, and you can get ventricular rupture. Now, as you know, the heart is surrounded by the fibrous pericardium that prevents overexpansion of the heart. And if blood is leaking out from the ventricle through a ventricular rupture, through the dead transmural infarct, then the pericardial sac can fill up with blood, again an acute life-threatening condition called cardiac tamponade, because the pericardial sac will fill up with blood and compress the heart, so the heart won't be able to re-expand with venous blood. And also another similar sort of acute mechanical deficiency can be a ventral septal defect, where you get rupture between the two sides of the heart, rupture of the ventricular septum, and this will lead to left to right shunting, sudden hemodynamic deterioration, and again the only realistic option to save the patient there is cardiac surgery. Now, another relatively common complication we see on the coronary care unit is pericarditis. This normally occurs 2 or 3 days after a myocardial infarction, and as the word says, pericarditis, we get some inflammation in the pericardium. And the patient usually notices that there's a qualitatively different pain. And the pain can be positional, but most common the patients will say the pain catches them when they breathe in. Now, the main thing here is not to give non-steroidal drugs such as ibuprofen or aspirin, because that reduces the healing of the myocardium. Well, it reduces the fibrous tissue formation to cause a fibrous patch over the infarcted area of myocardium, and that's associated with increased risk of ventricular rupture. So do treat these patients' pain, of course, but treat it with paracetamol or treat it with opiates. And of course, we must never lose track of the fact that we're treating a holistic human being here, so they've got psychological needs, spiritual needs, social needs. We need to be aware that there might be denial, there might be altered body image, there might be anxiety, the patient might be worried that they can't get back to work and look after their family, there can be depression. So we have to look after the heart to keep this patient alive, of course, but then especially in the days, months, weeks, years after an infarction, these patients can benefit greatly from our ongoing professional caring support.